to my talk about MPN progression. All right, so the title of my talk is MPN Progression, Is It Predictable and Is It Preventable? I have no disclosures, and I thought I'd start off with a slide. Maybe it's a little too late to mention this, but in case somebody here doesn't know what MPNs are, I thought I'd put this slide up here and actually describe what MPNs are just briefly. MPNs are myeloproliferative neoplasms. They are blood cancers, and they are categorized into three different subtypes. All the way on the left, essential thrombocythemia being the most indolent of subtypes, and on the right, primary myelofibrosis being the more aggressive of the three subtypes. The cartoon here is really supposed to give you an idea of what are some of the characteristics of these subtypes. In essential thrombocythemia, we primarily look for abnormal platelet count. So elevated platelets is the characteristic for this disease, and it is very unlikely or unusual for patients with ET to have elevated white blood counts or have abnormal hemoglobin or red blood count. Polycythemia vera, on the other hand, is primarily a disease of the red blood cells. So patients do or must present with an elevated hemoglobin or red blood cell count for them to actually have the required criterion to make the diagnosis of polycythemia vera. But we can also see elevated white counts, we can see elevated platelets. In myelofibrosis, primary myelofibrosis is a much more heterogeneous disease. The way I think of it is you can really have a patient present with any constellation of signs and symptoms. It can present with high counts, low counts, but what's more characteristic for myelofibrosis is the presentation of scarring of the bone marrow, abnormal blood cells that circulate in the blood, they're not supposed to be there, and also splenomegaly or enlarged spleens, which are more common in patients with primary myelofibrosis. What is common between these three very different heterogeneous subtypes is the genetic mutations, the drivers or the engines, if you will, that lead to these diseases. And Dr. Rezar highlighted the JAK2 mutation being the most common one across the board. It's essentially all polycythemia vera patients have a JAK2 mutation, but patients with ET or myelofibrosis, approximately 50 to 60% would have this mutation. The second most common being CALR, third most common being MPL or MPL. And it's important to think about the similarities and the differences of these diseases when we're going to think about how one disease becomes another. Some of us like to think about these diseases as a continuum, although, I would say the majority think of them as separate entities that can evolve from one to the other. So looking at ET and PV, for instance, both of these more chronic indolent MPNs can become aggressive and turn into myelofibrosis. Myelofibrosis within itself has actually been reclassified in 2016 to have the prefibrotic myelofibrosis and overt myelofibrosis as distinct entities within PMF. And what that means is a patient who presents with the prefibrotic myelofibrosis where their bone marrow is not as scarred, they don't have as advanced disease, they may not have the abnormalities of the blood counts that you would expect in the kind of the more advanced stages of the disease. They could also progress to a more aggressive form of myelofibrosis within itself. And then there's also instances where ET could evolve to PV, although some might argue that if you diagnose PV in somebody who had ET, that perhaps it was PV all along, but it was masked for one reason or another. So, it could be a little more complex than that, and there are several publications out there, and there's actually an MPN Research Foundation effort to kind of put together what really progression is and how do we diagnose progression, how do we predict progression. But there are some intermediaries between these different diseases. So a patient who has ET, who has some fibrosis in the bone marrow, does not necessarily have post-ET myelofibrosis. So it's very important that when you're in that stage or that phase where there's questions about your diagnosis, that you speak to a specialist about what are the criteria, do you meet the criteria, are we concerned, what can we do about it? So the criteria that are out there, and actually Dr. Mesa was part of the IWG, the International Working Group for MPN Research and Treatment, I've actually put together a list of criteria for the diagnosis of post-ET myelofibrosis and post-PV myelofibrosis. And the requirements were simple. There are two requirements that are major requirements. The first one is you had to have ET or PV to begin with. But the second one is the bone marrow biopsy showing grade 2 out of 3 or 2 to 3 out of 3 fibrosis as shown in this figure here. Now, before we do a bone marrow biopsy, I think it's important to recognize that there are clinical criteria that are also, although not required, but you do need 2 of them to actually fit that diagnostic criteria. So when we think about disease progression, we look for, are patients experiencing more symptoms, increasing symptom burden, but there are specific symptoms that are even more worrisome, as Dr. Mesa had highlighted, including night sweats, including more than 10% weight loss. So having symptoms that are attributed to the disease, as long as you've done a thorough job ruling out other conditions, is already one of the 2 criteria that adds to that diagnosis of post-ET or post-PV myelofibrosis. Having splenomegaly, so enlarged spleen, and again, there's some nuances to how that is assessed. Sometimes we look at size on exam, sometimes scans are done, but generally splenomegaly that's either new or progressive is also a sign that we would consider for progression. Anemia is an important one too, so patients with polycythemia vera who are typically overproductive in red blood cells can become, at some point in their disease, more anemic. And it's very important to recognize whether that mild anemia, or at least the early signs of anemia, is attributable to a treatment or the disease itself. Because certainly if it's attributed to the disease, that's again one of the 2 additional clinical criteria for you to be thinking about disease progression. So what about progression to MDS and AML? So for ET and PV, it's rare for either of these diseases to go to MDS or AML, myelodysplastic syndrome, or acute myeloid leukemia. Generally, the more common way that would happen is for either of these diseases to evolve into myelofibrosis before transforming into AML. So we don't. It's possible to happen. We do see it, but it's not as common. Think about these more aggressive leukemias. What we want to look for is any signs of severe cytopenias or low blood counts, as well as the presence of these immature cells we call blasts in the peripheral blood. Blasts that are 1 or 2% are pretty common to see in patients with myelofibrosis. You might even see them in PV. But blasts generally at 10% or higher, that defines accelerated disease where really your Prius is turning into a Corvette, right? So that is a cause for concern. When you hit the 20% mark or above, that by definition is acute leukemia. But in our practice, because we really don't see patients with myelofibrosis have as many blasts as 5% or 10%, that cutoff is a little bit of a gray area. So finding something more than 3% perhaps is concerning enough, and actually is one of the prognostic factors in thinking about survival of patients with myelofibrosis. If you have too many blasts, that's generally not a good sign. So is MPN progression a big deal? And the short answer is yes, it is. Secondary myelofibrosis arising from ET or PV carries a median survival of about 5 to 6 years. So on average, 5 to 6 years, it's too short. MPN blast phase, or really what we also refer to as acute leukemia arising from MPNs, has a median survival of less than a year. So certainly this is a big deal, and it's something that if we can avoid, we want to avoid it at all costs, because treating them can be difficult. So importantly as well is to highlight that the longer patients are alive with ET or PV, without any blood clots, because blood clots can be fatal. Heart attacks, strokes, certainly high cause of mortality. But as patients are living longer, as we're doing a better job at controlling blood counts and preventing these events from happening, patients are living with their disease 30 years or more. And when you get to the 30 years time point in patients with polycythemia vera, you have about a 50% chance of having evolved to myelofibrosis. And as you can see, these curves actually, what's important to highlight is not only that myelofibrosis becomes a more common issue, but also really the slope here. So initially, we do worry about clotting as being the major risk, and that kind of levels off later on. Whereas with disease progression, you kind of get that slow incidence of myelofibrosis the first couple of years, and then it really takes off the longer the disease has been around. So what about ET? And I think this is important to highlight because ET and PV are different diseases, but also ET has additional genetic considerations. You know, PV, 98% of patients have a JAK2 mutation. But in ET, we also have to talk about CALR, we have to talk about MPL, and we have to talk about patients who are triple negative for these three driver mutations. So we published a recent paper actually from our experience at Weill Cornell, a couple of hundred ET patients who have been treated at our center for years to decades. And this paper was actually in correspondence to two important papers that came out with 1,000 patients each from the Mayo Clinic and the Italian group that actually showed we cannot really think about ET as being the same disease when you have the different genetic mutations. And we were actually not the first to show it, and neither of the three of us were the first to show it. There was actually publications on this dating back 8+ years ago to show that patients who have the CALR mutation actually do have a higher risk of disease progression than patients who have JAK2. That is also true for MPL, a little harder to prove because less patients carry this mutation. But in this figure here, which is the myelofibrosis-free survival probability, the percentage of patients who are alive without myelofibrosis is significantly lower for CALR than it is for JAK2. Maybe the good news for patients who have CALR is that there is no difference in overall survival. So despite the differences in disease progression, the overall survival for ET across the subtypes seems to be similar. And that really highlights the heterogeneity of the disease and the long duration of it, that there is an opportunity to intervene, medications can reduce risks, and also, you know, if thrombosis is not really a major risk factor, perhaps we should start shifting some of our focus, or really majority of our focus, towards preventing disease progression, because right now I think we do a pretty good job at preventing thrombosis. Let's try to prevent disease progression from happening. So what about disease progression to acute leukemia? And there's sort of a solid and a dotted line here. I think the dotted line is probably more relevant because it takes into account an analytic approach called competing risks. So patients who may have other, competing issues like clotting issues, certainly might change your statistics about your probability of having acute leukemia after living with a disease like ET, PV, or myelofibrosis. So that range, I think is variable between, I would say, even 5% to 20%, depending on what the initial diagnosis is. Certainly for primary myelofibrosis, the risk of transformation or progression, I should stick to that same terminology, the risk of progression is closer to, I would say, 15 to 20% in primary myelofibrosis. So what are we doing about MPN progression? The short answer is not enough. There are no risk models to predict it. I'll explain what that means. There are no clinical trials that are geared towards preventing it. And the treatment that we now know prevents progression is underutilized. So I'm actually going to take a backwards approach and start with point number 3 here. And I thought I'd give PV as an example here and kind of show the treatment landscape of PV and what we do right now based on consensus guidelines and what we could do better. So if you're a patient with polycythemia vera, you're generally classified into this low-risk basket or high-risk basket. If you're low risk, that's pretty simple. Under the age of 60, you never had a blood clot, right? So if you're in that category, then what you're offered is treatment with phlebotomy, a daily aspirin, and generally cytoreductive therapy is reserved for later, unless the patient has severe symptoms or other particular criteria that require earlier treatment. If you're a high-risk patient, simply it's your 60th birthday today, you welcome to the world of high risk. Now we should start you on a cytoreductive therapy. The first-line treatments that we would use in that situation would be interferon alpha or hydroxyurea in the first line. And then certainly we have ruxolitinib as a second-line option for those patients who either do not respond to or cannot tolerate or cannot receive one of these first-line drugs. And it's very important to highlight that clinical trials is really a key component of the development of standard of care, new drugs, and it's very important to consider what are some clinical trials that are available. Are they applicable? Are they good for me? Are they better than standard of care? And I think that's a question that a lot of trials try to answer is, can we do better than standard of care? So the point I'm going to try to relate today is, can we prevent progression with available treatment? So when we asked ourselves this question, I'm sure many have asked this question years and decades ago, but when I personally asked myself this question, as I was doing my fellowship under Dr. Silver's mentorship, I asked, well, how can we actually prove that a drug can prevent progression? And I recognized that due to the progression rate, and as you remember from those figures, the first couple of years from diagnosis, we don't really get that many events. And it's 50%, but over 30 years. So how do you design a study for a short period of time to be able to study that and say, I give half the patients one drug, I give the other half a placebo. How can I tell that this drug is actually better than placebo in preventing progression? So we recognize that that actually requires a really large sample size if you're going to do it over a short period of time. But we had the unique opportunity that Dr. Silver had started using interferon back in the 80s. And we had the unique opportunity to look back decades at all the patients who had PV and were treated with interferon to see if it actually has prolonged their survival or prevented their disease progression. And so this was our study. It was a single center study, a large number of patients, 470, over a median follow-up of 10 years. We were also very happy to see that our findings were actually validated in a multi-center randomized clinical trial, really the highest level of evidence, and this study also now shows some promising results about preventing progression. And I'll talk a little bit about ruxolitinib as well and some more recent data about its ability to potentially also reduce events and disease progression. So these are actually some of our findings from the paper we published a few years ago. This shown here is the percentage of patients who have had a degree of fibrosis consistent with the required criterion for post-ET or post-PVMF. So if you look all the way at time 0, very few patients had a grade 2 or 3 fibrosis. Right? That makes sense. You don't see that often in new diagnosis of disease. But over time, if you were to only treat with phlebotomy, almost 74% of patients at 10 plus years will have fibrosis grade 2 or 3 in their bone marrow. And if you compare that to patients on treatment, you see a little bit less of that with hydroxyurea, although it isn't statistically significant. But where you see the dramatic significance is the use of interferon in reducing the fibrosis grade over time in patients treated with interferon. And so how that translates into a survival curve, again, when you look at the probability of being alive without myelofibrosis, you see that the probability at 20 years on interferon is about 85%. And the probability with phlebotomy alone or hydroxyurea is around 50 to 60%. So on average, when we did this in a multivariable analysis, we included some factors that are different between the patients. We found out that interferon independently reduces the fibrosis progression risk in PV by 9% per year. And it was actually reassuring to see that AML rates were low, just generally across the cohort, and particularly with interferon. The study that gave this additional credence was the randomized trial from multiple centers in Europe that showed here in the red line that the event-free survival on Ropeg interferon was superior to patients who received hydroxyurea at about 94% versus 84% at 7 years. Okay. So lastly, I'd actually highlight one more study that is important because this study is, to my knowledge, the first study that gives us more information about myelofibrosis-free survival in ET. This study was actually designed for children and young adults. So it's an AYA population with a median age of 20 years of diagnosis, so they're all young. There are 348 patients were enrolled in Europe to either receiving interferon or receiving other forms of therapy. In fact, I'll actually correct that and say this was a retrospective analysis. So patients were treated based on the physician's judgment about what's most appropriate to them. But when they looked retrospectively, they found out that, in this primarily ET group of patients who are young, those who received interferon, a small fraction of them, none of them had disease progression to myelofibrosis. So 100% had no disease progression, whereas if you look at the other group, you will see at 20 years later, about 75% do not have disease progression. So that's a dramatic difference in such young people. So I think that although this is an abstract and not yet published paper, I think this is also very important when we start thinking about our quote-unquote low-risk young patients who are not receiving interferon therapy. This is actually an important slide. Now, this was a PV Reveal study was actually running between 2014 and 2016, enrolling patients prospectively, just observational. The patients were treated per standard of care, per their physicians from academic community centers. And they looked at many different questions to answer. And I think this is a very important registry and has generated a lot of, publications and findings. But one thing that really attracted my attention, that, the caveat being this was done before all the studies I showed you, is that the fraction of interferon-treated PV patients on this study of 2,000 plus people was 1.5%. So, again, I hope that this statistic is much better now. We don't know that for sure, but I think this raises the point that awareness of these diseases and how they're treated and how to prevent progression is very, very important and key to fighting disease progression. So what about ruxolitinib? Because this is not only an interferon talk, let's talk a little more about ruxolitinib, which has been around for quite a long time now, 10 plus years since its first approval in myelofibrosis. This was an elegant study run in the UK. It was multiple centers that actually randomized patients who had PV, quote unquote, high-risk PV, to either receiving ruxolitinib or receiving what was considered best available therapy. And what was very important from this trial is to show here that, at least in my opinion, is that the event-free survival, which includes disease progression, includes blood clots, really any disease-related event, was dramatically less in patients who are on ruxolitinib versus the other therapies. So that already is actually encouraging to know that it's not just interferon, but there might be other drugs out there that really can reduce disease progression. We just need to do a better job at showing it and at recognizing when to use these drugs. But what I would like to highlight mostly about this study is that the benefit of event-free survival was clearly linked to the reduction in the JAK2 allele frequency. So while the majority of patients benefited, the ones who really benefited were the ones where the JAK2 percentage had reduced more than 50% from its baseline. And this was actually also validated with an independent study in Italy for both ET and PV, where ruxolitinib was used for one reason or another. And then they looked back retrospectively to classify patients into those who achieved a complete or durable molecular response versus those who only had a partial response or those who had no molecular response or no change in their JAK2 levels. And what they showed here is if you do achieve that deep and durable response with ruxolitinib, none of the patients had any disease progression over the 16 years period total that they were followed. So when we go back to the PV landscape and I'm talking about preventing progression, I think rather than the current treatment landscape, the evolving treatment landscape of PV should take into consideration bringing up some of the therapies that are shown to prevent progression, or at least running a clinical trial that will, once and for all, definitively show that this should be the new standard of care. So going back to these points, we can do more. We need consensus on early usage of disease-modifying treatment. So let's talk a little bit about clinical trials to prevent it. I'm actually not going to spend a lot of time here, but this actually is a theoretical statistical analysis that tells you how many patients you would need to enroll in a study of patients with PV to show that interferon can prevent progression, right? So if you were to run a 2 or 3 year study, it's too short, you would need more than 1,000 patients, sometimes even 10,000 patients. So these are not feasible studies to run. If you extend the duration longer, perhaps 5 or 6 years, then you might be able to run a study with a couple of hundred patients where you show this. But this clearly shows how difficult it is to study disease progression in these kind of chronic indolent phases of the disease. So we can potentially run these clinical trials. We just need to understand how to choose the right patients. Who are the patients who, are more likely to have progression? Can we predict it better so that we can design a trial that will answer that question? And that comes down to what we know so far and what we can do to develop a model that predicts progression. And Dr. Bessa talked about symptoms, so I won't discuss symptoms here, but there are other clinical features that can signify disease progression. We think about splenomegaly, at least in PV or ET, as being one potential correlative to disease progression. And then we look at laboratory abnormalities, including anemia, having low platelets or thrombocytopenia, having a high white blood count, or having an increased number of what we call, again, blasts, the leukemic cells circulating, as well as the JAK2 allele frequency, or really the driver allele frequency, whether it's JAK2, CALR, or MPL. And then, is there a role for other mutations? So for the sake of time, I'll just be brief, but we did show that splenomegaly in PV can have some predictive ability in telling us if myelofibrosis is likely to happen in patients with PV. But as you can see, even those who don't really have an enlarged spleen, they do experience disease progression. So it's not a perfect biomarker by itself. And splenomegaly in ET is rare. In myelofibrosis, it is pretty common, and there's variations in sizes, smaller spleens, larger spleens. So it's not entirely clear how that could be predictive of progression, but we do know it's associated with higher disease burden, higher symptom burden. And there are some studies loosely associating that with survival as well. Anemia is very important. Patients who are anemic, and here we talk about hemoglobin less than 10. We do start to get more concerned about disease progression when the hemoglobin gets under 10, because if you look here at the severity of anemia, at least from the context of using ruxolitinib in myelofibrosis, patients who had no anemia when they started ruxolitinib for myelofibrosis really had the lowest risk of disease progression, whereas patients who started off with severe anemia had a higher risk of disease progression. What about the JAK2 allele frequency? So I think it's important to actually have this profiled in the beginning or from the diagnosis to understand what is your mutation, what's your driver mutation, do you have other mutations, and what's the frequency of this mutation in the blood. There have been several studies that have tried to link the JAK2 allele frequency to disease progression. And finally, we had a nice meta-analysis published recently that pools all these studies together to show that patients who start off with a high JAK2 allele frequency are the ones who are more likely to develop disease progression. That being said, I think it's important to ask a separate but related question: is lowering the driver mutation allele frequency going to reduce disease progression? And there's some skepticism about this, but I think the MAGIC PV study, which I presented earlier, was actually a good testament to that yes, we could find patients who run high JAK2s at diagnosis, but if we get them on a drug that's capable of not only improving their symptoms, their blood counts, but also improving their driver mutation or allele frequency or their clone size, that these patients have a better event-free survival on the long term. And this was also shown in the ROPEG interferon study in polycythemia vera, where and I think Dr. Hasselbach showed this in one of his slides, where the JAK2 allele frequency reduction on interferon was dramatically, significantly lower than hydroxyurea and pretty durable at less than 10% on average after 6+ years of therapy. So lastly, there's been some more work in the genomics world trying to incorporate all this genetic information into some model that can tell us, are you at high risk of progression, are you not? And while this actually was published in the New England Journal of Medicine and got a lot of traction, we don't routinely use these predictive models to inform therapy. But what this elegant study published by the Cambridge group showed is if you have chronic phase MPN, so this is really ET or PV, a transformation to myelofibrosis is generally linked to some of the clinical factors I discussed, including blood counts, low hemoglobin, anemia, low platelets, having a large spleen, other clinical risk factors. But there is actually a big role played by genetics and biology. So you can see CALR here, at least this is for ET, but you see all these other mutations that can play a dramatic role in disease progression. So I tell all my patients that at diagnosis, it's important for you to have an extensive genetic profiling, or let's say targeted profiling of the myeloid-related genetics using the technology, what we refer to as next-generation sequencing, or NGS, to understand if you have additional mutations besides the driver. And then this is also true for patients with myelofibrosis who carry high-risk mutations. Their chances of developing AML do increase, and we start to think, about how do we manage these patients, outside the box. Is standard therapy sufficient? Do we need to think about clinical trials? Do we need to think about a bone marrow transplant? So these are all important considerations when we think about the disease, both clinically and biologically. So with that, I'm going to wrap up. I'm going to say, what are we doing about MPN progression? I'm going to summarize. We can definitely do more. There are currently no risk models to predict it, but with all these risk factors that we are already aware of and the ongoing efforts to develop models, it seems like a low-hanging fruit. Certainly with the advent of the computational power to do artificial intelligence, machine learning, it'd be one day my vision is to see a personalized risk predictor for a patient. So you come to the clinic and you're not getting lumped into that population statistic, but you're getting a personalized predictor of How do we think you're going to do? What is the best treatment for you individually? And I think that's in our near future. So that will certainly facilitate running clinical trials, because if we have such tools, we can run these trials at a shorter time period and not have to enroll tens of thousands of patients. And then finally, and importantly, is recognizing the treatments we already have that prevent progression. We really need to have a consensus about, introducing these therapies earlier to prevent disease progression. So final conclusions, we think it's predictable. MPN progression can be predictable, but we need to prove it. We know it's preventable, and we need consensus on treatment goal and trials that support it. And with that, I'd just like to acknowledge all our patients, all of you who are here, our patients who've participated in research or in any shape or form, and as well as our team at Weill Cornell, and really all those who fund and support our research efforts. So thank you to all of you. And I'm sure you have a lot of questions, so we'll hope to address that later. Okay.